I work in 4 different environments: the Netherlands, New York, and in Santiago in Chile, a Roman Catholic hospital under the direct supervision of the Pope. And so clearly, well, I don't think the Pope will directly influence what we're doing, but there are guidelines. And so clearly, this case would be handled completely different in these 3 environments. So it's a little bit difficult for me to, let's say, move between the environments because I have my opinion and I have them in every place. But I'm fortunate to, let's say, at least be familiar with all the arguments. So how I decide when ICU treatment is appropriate. There are no conflicts of interest. No industry is interested in end-of-life stuff, so that's always easy. So the question was, how will I go on? So do whatever you did and do whatever is necessary to control the problems that you have, or stop and call it a day and have the patient die, or ask someone else. In my practice in the United States, that's get rid of the problem by calling someone else. You call ethics, or you call well, in New York, you also have to call judiciary in these cases. And so you let them deal with the problem, and then when they come up with a suggestion, then you do it. So that's where we start. Now, I think you start with a moral framework. You start with what are we here on Earth doing for, as a medical doctor or a nurse, what's the purpose of of what we do? And so we have a moral framework as doctors and nurses. And the first thing, and everybody knows that, is do well and do no harm. And I think we have to adjust do no harm. You cannot practice intensive care without doing harm. As my colleague and clinical ethicist in Rotterdam always says, the hospital is probably the worst place in the world where we, by regular intervention, do harm to everyone that enters the front door, because that's the basis of medicine. If you want to treat cancer, you have to give a drug that will kill other cells as well. You will get bald and you will get nausea and vomiting. If you want to remove the tumor, you have to open up the patient. That's harm. And so we have to say net harm. So intensive care treatment is always accompanied by some kind of harm, and so what you want is that the harm you do does not outweigh the benefits to the patient. And as you saw in this case, there's already a lot of harm. I mean, she lost, or he lost a leg because of ECMO. The intention of ECMO was completely acceptable. I think at least in every context I work, we would have started ECMO in a case like this. The harm is amputation is a complication, of course, so there was already harm. And I think that colonization with gram-negative bacteria is harm as well. It's preventable, and so if you have it, it's harm. And then, of course, autonomy. And that's the complicating thing in this case. There is no autonomy. There is no one who can, let's say, represent the patient. Of course, you can have the court address someone. It frequently happens in New York. We have a lot of patients that we don't even know the name of. And so someone is appointed by the court to represent the patient. But of course, they do not represent. They try to represent this moral framework. But you don't have a brother, a sister, a mother who can tell you about the history and what the patient would like or not like. So that's very difficult in this case, because if you have a patient who is competent and says, no, please, articulation, are you kidding? Let's stop. I'm done here. Then it's easy, because the patient is in charge. Another aspect of autonomy that's frequently, let's say, a problem, especially in the United States. What about the other side? You have the side of a patient, I don't want ECMO. That's easy. Then you don't do ECMO if the patient is competent. But what if the patient said, I want ECMO? And you think, that doesn't make sense. And they say, well, she could go home on ECMO, no? I mean, Maquette is already working on ECMO machines at home. And so then the autonomy becomes, let's say, much more of a problem. And then do justice. And that's a problem in this case as well. The patient is in the ICU for 7 weeks. The majority of the audience will say, let's stop, let the patient die. If you don't, you occupy a bed that cannot be used for someone else. That's distributive justice. If there is someone else who would actually benefit much more from your bed or your resources, better said, then that's an element that you should take into account as well. So that's the moral framework that we work with in this case. We developed the concept of inappropriate care. And I think that's more reflects our current day-to-day work. It's either appropriate or it's inappropriate. And inappropriate is not proper. It's untimely. Like, for instance, a patient is suffering from multiple severe comorbidities and chronic organ dysfunction. In many cases, patients like this won't be admitted to an ICU for invasive mechanical ventilation, for instance, because we think that the harm we do and the intervention we do does not result in a significant endpoint. Or there is no basis for treatment because you can't. Or the patient is not responding at all to treatment. We just had a discussion about blood pressure in the earlier hours before this. And if you try to increase the blood pressure is 45 and nothing happens, then at some point you have to call it a day, because all the harm you do with all the interventions and there is no effect whatsoever, at some point becomes inappropriate. Or the patient is not critically ill, and that's the most let's say, difficult part of inappropriate care. The patient is not critically ill, but cannot survive outside an ICU. So, for instance, the patient is on a ventilator and cannot survive outside the ICU, but also cannot go home or to a nursing home or whatever. That's, of course, extremely challenging. And then you have the disproportionate care as an element of inappropriate, and that's the problem here. You do so much. You amputate a leg, you have ECMO, you have treatment, you have massive blood transfusion every 2 days. That's a lot of interventions that you do, and there is, at least for 57 days, there is no real benefit, at least not something that we can measure. The patient doesn't wake up, the patient doesn't start to respond minimally or nothing. Basically, there's no change between the time when he was, let's say, ready to be awake and was not awake, and 57 days at the end of this period. And so that's excessive. It feels like too much or even more than enough. And of course, the unlawful, if the patient doesn't want, you cannot do it. And if it's ineffective or pointless in brain-dead patients, we don't treat, at least if you accept brain-dead elements. And even in the United States, there's only one state, I think it's only New Jersey, that doesn't recognize brain-dead as being dead, legally dead. And so there the family can force you to continue treatment even if the patient is dead, brain dead. And that would be, let's say, futile. That's a very small proportion of patients. So that's the framework, and I think in this case we're talking about disproportionate care. So if you talk about disproportionate care, you're talking about what's the end point. What would I maximally gain in this patient? Because if you gain very little and you have to do a lot, that's a lot of disproportionateness. And so if you want to quantify or qualify disproportionate, you have to have an opinion. You don't have to be right, but you have to have an opinion about what will be the end point. And so that's my question. What would be the best outcome that we could foresee in this 21-year-old? A, acceptable quality of life. That's, of course, to the appreciation of the patient. and could maybe be even independent, or B, acceptable quality of life in a nursing home, no quality of life, there is no social interaction, at least for now the patient doesn't interact. He will be in a nursing home on a ventilator and tube feeds, or as we do in New York, trach and PEG. So put in a trach and put in a PEG and bring the patient to nursing home or long-term care facility. Or D, the patient will not survive the current admission, even if we do everything that we can do. So please vote. So the majority thinks that there is, whatever we do, this will never result in even survival. If I think, and that's something that I introduced when I started my practice in the United States, and it's a concept they have a lot of problems with. If the team, not an individual, I think it's very wrong that an individual comes up, but if you as a team come up to D, this patient will never survive. From that point on, the only thing you do is harm. Because what we are here for is to restore autonomy of a patient, so get the patient in a situation where he or she says, well, I mean, it's not great, but it's acceptable. And I have some fun in life, and I'm autonomous, maybe with help of family or whatever. That's the goal. Or as I said in the Philips Lung Symposium, the only goal in ICU is get your patient out. That's the goal of ICU in an acceptable quality. If at any point you say, well, this is impossible, for whatever reason, then there is only harm. Because you cannot perform ICU without harm. You just decided there will be no benefit, and so that's it. So as soon as you reach consensus, there will be no outcome. I think legally, no, not legally, that's different. But ethically, that's the point where you are forced, should be forced to stop treatment because the only thing you're doing is harm. So that's 46%. But, and 34% says, well, the maximum that we could gain is a nursing home with no quality of life because the patient will never interact with anyone given his neurologic state, and he will be on a ventilator with tube feeds. And so the vast majority of patients thinks that there is no reasonable endpoint. Now, the C point, of course, you need someone else. Is this okay? You would love to have family that says, no, he would never accept this. I had a patient in Bellevue a few weeks ago. He was close to 80 and he was taking care of his mom, 90-something. And he was an active. He had his own company. He was in air conditioning stuff, and he had a daytime job until Saturday. And in the evenings and on Sunday, he took care of his mother, and he had a massive stroke. And so I talked to the family, and the family said, if he cannot get back to his normal job and take care of his mom, that's it. And then he developed pneumonia. Of course, they all develop pneumonia. And I said, well, I mean, this is not likely to go well. He will probably never reach the state that you want him to be in. And they said, but we want to treat the pneumonia because we need some time to, let's say, convince ourselves that this is it. And he was in the same state, not responding to anything. He opened his eyes, but there was no response. And they said, we need at least a week to convince ourselves that this is it. And so I said, okay, then let's treat the pneumonia. In the United States, you're bound with by legal stuff. And then the patient became ventilator hypoxemic. And the family said, so we want him on a ventilator. And I said, I'm not willing to do that. That's an unacceptable trashing of inappropriate and disproportionate care. Because what you think he needs or minimally wants will never be reached. And now you ask me to do even more harm by putting the patient on a ventilator. that will reduce his ventilatory drive and will be difficult to wean him off, and he will end up in a nursing home on a ventilator. That's unacceptable for me. So I'm very sorry. I'm not going to do this. And they said, explain again. So they had some trouble getting it. And then they said, oh no, then we don't want ventilator. And so if you introduced it disproportionate, like this is not acceptable for me, and if you still want it, we have to find another doctor to do this ventilation, because I'm not going to do this. And you're clear about why you think this is disproportionate. I've never met a family who says, yeah, let's find another doctor and do this.
Just wait, let's leave this slide on for a second. By hand raising, because I of course I didn't prepare a slide to vote, but how many of you would, if they choose option D, would stop treatment within a reasonable time?
Okay.
Okay, that's the vast majority. And then C. It's far less, yeah.
Yeah, and that has to do with the next problem, and that's the withholding and withdrawing. And I get it. I get it that there is emotionally a complete difference between not offering something and taking away something. I also work at Columbia in New York, a big ECMO center, and I've had a lot of discussions with Dan Brody whether you should remove an ECMO in an awake patient. That's something that we do in Rotterdam. If in Rotterdam there is no option to get off ECMO because you cannot transplant lungs or heart or whatever the problem is, then the patient is destined to be for the rest of his or her life on an ECMO. That's unacceptable. That's no quality. And so we talked to the patient and said, we're very sorry, but we're going to remove the ECMO device. And in the United States, that's considered cruel. That's a cruel, and it's extremely difficult. And basically that's where it comes back to. When you talk to the individual doctors and nurses, it's about the emotional impact it has on you when you stop an LVAD in a patient. That's terrible, because almost instantly you stop and boom, they're dead. And so it feels like you killed the patient. And so I get the difference, but ethically there is not a lot of difference. So what we did with Charlie Sprung, or what Charlie Sprung did, is he did something like a Delphi procedure, and one of the questions was withholding versus withdrawing. And so if a medical decision is made that the patient's chances of surviving are extremely low, or the patient would not want, then life-sustaining treatment may be withheld. So don't offer, for instance, ECMO. Withdrawing is the opposite. The patient is already on the device, ventilator, ECMO device, and there are no chances of survival or very low, then you can withdraw. And so we asked the participants in the Delphi process, do you agree? So this is, I agree or I do not agree. And so let's vote. Let's vote what your opinion is on, and I use the whole spectrum because otherwise it takes too long. So withholding and withdrawing. I'm okay with both. I'm okay with withholding, not offering a treatment, but I don't like withdrawing. I'm not in favor of withholding. Every patient deserves a chance. When the patient doesn't respond, then withdrawing is okay. And the other one, I'm not in favor of any, either withdrawing or withholding.
I've heard a nice reasoning to solve your problem. That if you withhold, you haven't tried the thing you are withholding. So there is a slight chance that you have some benefit. If you withdraw a treatment that has proven not to be efficient. So that's why withholding is ethically harder than withdrawing.
Yeah, that's a good point.
Yeah.
So the majority is okay with both. Only a small group is not in favor of either. 1/5 is C. That's basically the case we're dealing with here. give everyone a chance. I think, at least in every context I work, we would have started ECMO in a patient like this, no question. So that would be C. In the study of Charlie Sprung, only 88% was okay with withholding and only 82% with withdrawing. So there's a significant group, this was intensivists, a significant number of intensivists who are not okay with either withholding or withdrawing. And so it's a clear, let's say, problem in clinical practice. Gordon Rubenfeld, already 15 years ago, so a lot has changed. He said the goal, he had some elements of end of life and withdrawing life support. And this is something that got my attention. Any treatment can be withheld or withdrawn. And that's the discussion I have with the team in Colombia. Of course you can withhold. You have no problem withholding cardiac transplantation or lung transplantation. A huge number of patients could benefit from heart transplantation. We don't offer it. We have no problem with withholding, but suddenly we have a problem withdrawing ECMO when there is no heart available or you're not willing to do a heart transplantation. That's a little bit weird. So let's vote on this. Any treatment, indeed, anything that you do in your patient can be withheld, somewhat more easy maybe, or withdrawn. Oh, sorry. So there is a quarter of the audience who doesn't agree that you can stop everything. I'm not sure whether that's a legal problem, because if you practice in Israel, for instance, you cannot withdraw a ventilator. I mean, whatever the state of the patient, it's by law that you cannot withdraw the ventilator. That's why Charlie Sprung came up with this, for us, weird concept where a ventilator turns up at a given time. And so the thought process is great because it deals with withholding and not offering. And so what Charlie did, he recognized the problem that a large group of patients is waiting on a ward, on a ventilator, until someone dies or is discharged from the ICU to come up to the ICU. And I've been to his hospital a few years ago, and yeah, that's a true problem. And so he said, I have all these patients without any prognosis in my ICU, and I cannot stop the ventilator to admit someone who has a much better chance of making a meaningful recovery. And so the law says you can't. And so we went to a rabbi, and you know, the Jewish are extremely practical, and he came up with an extremely practical solution. He said, yeah, that's true, you cannot withdraw. You cannot stop something that keeps a patient alive, but you can decide not to start it. So if you have a ventilator and you decide that the ventilator tomorrow at 9 o'clock stops, boom, off, then you have to decide, do I turn it on or do I keep it off? And you can do that. And so if you decide not to turn it on again, that's completely okay, no problem. And so they went to the parliament, and the parliament said, yeah, basically, yeah, that's a very different situation. I mean, for us, it's like, what are you talking about? I mean, what? But, I mean, it dissects the problem to not starting and to taking away. And taking away a ventilator, we studied it in the Netherlands. In the average patient, if you take away a ventilator, 20 minutes later, the patient is dead. There's a clear connection to what you do and the results. And so emotionally, much more difficult. But it's a weird solution of a very common problem.
They have even taken it even further. I've heard from Charlie that there's now somebody who a religious leader said, you can see every breath as a new therapy. So after exhale, you start a new therapy, inhale, so you can switch it off then.
Yeah, that's taking it to the extremes. So basically, at every moment, you can turn off the ventilator only in expiration, not in inspiration. Very different.
It's strange that we make rules and then try to bend them as much as we can. Yeah.
Yeah. There's a very interesting paper, an old paper, how gravely ill becomes dying, and he tried to, let's say, give some key elements of end-of-life care. And one element got my attention, and it's especially prominent in my New York practice, much less in Santiago, where people are much more religious, and much less in the Netherlands, where people are much more practical. If I need to be in a wheelchair in a nursing home, are you kidding me? On a ventilator? No, my friend, that's not going to happen. So much more practical, very religious in Santiago. And that's a widespread health desire not to be dead. And we frequently forget to, let's say, discuss about this with an awake patient. Because what's actually driving the patient to remain on a ventilator or an ECMO or whatever device you have? In many cases, they are afraid of not being relevant anymore. Because the main aspect of death is you're no longer there, you're no longer relevant. It's a discussion we had in the paper that we wrote to more than a year ago about doctors assisting in end of life. And so doctor-assisted suicide, and we had this pro and con debate in critical care medicine. And we had these huge discussions of what it meant to be dead. And one of the elements was, well, if I'm dead, I'm not there anymore, I'm not important anymore, I don't matter anymore. I become useless. And for many patients I have encountered in my practice, that's a real fear. And the other fear is, of course, the dying process, which is usually easily covered. But not being important, not being relevant anymore is in some patients a big thing. It's an existential angst. It's the fear for ultimate insignificance, annihilation, stuff like that. But a lot of patients will want to talk about it. And if you have an honest discussion and you use the right language, then it's not that difficult to, not emotionally is difficult, but it's not difficult to have the conversation. The problem, of course, is our inability to predict the ultimate endpoint. And so I stopped giving these numbers when I had a discussion as a young fellow with a family. And so the family said, so how is father doing? And I said, well, if we have like 100 of your fathers, I think about less than 10 would leave the hospital alive. And then the family looked at me and said, and so what's the chance he's one of the 10? Yeah. Lost. Yeah. So I was trying to communicate, he's very sick and I'm very concerned and he's very likely to die. And immediately they focused on survival and asked me, what's the chance? Yeah, well, I just tried to tell you, I have no clue. And once you start to communicate that you have no clue, then even a 1% chance is something very relevant for many families. Oh, so there is a chance. Oh, well, let's go for the chance. And so our inability to predict is a major limitation. And that's why I think trust in discussions like this is very important. And then again, you're lost. You have a patient who doesn't communicate. There is no response. You have a legal representative, but the person has no connection whatsoever with the person in bed. And so that's a very difficult conversation. So that's why, at the end, the group from Jean-Louis Vincent in Brussels came up with, okay, if you have an inability to adequately predict that this patient will survive or not survive, then let's try. What's wrong? What's wrong with dealing with your insecurity? I don't know, by trying. And so he came up with the ICU test, and he said, okay, you set your goals, before you start, you set your interventions, and you set your interventions to the context. So in a patient where ECMO is no option, you don't offer ECMO, of course, but you set everything that will get you to the relevant endpoint, and then you reassess after 1 day, 2 days, or whatever you set. You make clear discussions with the family members, and after the time is over, you assess, and then you decide whether you stop or negotiate. And that's how Jean-Louis came up. And so my question is, who uses this trial or test of intensive care? So you admit the patient with a goal and therapy options, and you reassess after a given time to make a final decision whether you go on or stop. Frequently, sometimes, rarely, never. That's interesting. So there's only a small group that never uses a trial of intensive care. Somewhat bigger group rarely, but more than 60% of the audience uses it frequently or sometimes. And I think it's a very valuable tool as long as you can make very good communication with family. Don't ever start a trial of intensive care and tell the family, well, we'll see in 2 days how the condition is. No, you have to be incredibly specific, because they will get you to the limits. If you say, I want the lactate to be less than 2 in 3 days, and it's 2.1, and you try to get your point across to stop treatment because it's 2.1, they say 2.1 or 1, that's 1/10. I mean, what's the problem? Let's wait another day and see if it then... You get into a lot of trouble. And so in some cases, you have to be extremely specific, and in the other ones, somewhat broad. I love the way Wes Eli says he communicates with family. He's very graphical. And so Wes said, when I talk to family about doing a trial of intensive care, I use graphical representation. And he said, you have 3 options. The patient or your family member improves. There is no change in whatever you decided the condition is, or it worsens. And he said, basically, there are only 2, because these 2 are the same. If there is no change or a decrease or a worsening, that's basically the same. So we have 2 options. You either improve or you're not improve. And then you define improvement. And so that's let's say, a clear way to communicate and not introduce an enormous amount of options to families at the end of the day. Together with Eva Vink and Eli Azule, we tried to come up with a concept of a trial of intensive care. And we said, well, it's about chances of functional recovery and autonomy. That's what you want to, let's say, reach at the end of the day. The patient has to be in functional recovery, at least by his or her definition, and there has to be autonomy. And then you have a spectrum. 0 chance, and you have 100% of chance. And of course, in this 100% chance of functional recovery and autonomy, there is uncertainty. And in the uncertainty, there is room for trial. If there is no uncertainty, there is disproportionate care. If you admit a patient with a 100% chance of survival, then the patient should not be in the ICU. That's, for instance, a reason to start a post-cardiac surgery medium care or a post-anesthesia care unit, where you admit patient with almost 100% chance of survival. They need some monitoring if something goes wrong or need some adjustment, and then they go to the ward. When I took over the ICU in Erasmus in Rotterdam, we had 500 patients identified as having 0 chance of dying. But we didn't have post-anesthesia care unit. So I closed down one of my ICU units, gave it to the anesthesiology to create a post-anesthesia care unit. They admit 1,000 patients to this unit, and they have zero mortality, and we admit very few patients to the ICU from this unit. So that's this end of the spectrum. The other end of the spectrum is 0% chance that there is no functional recovery or autonomy. And also that part has uncertainty, and also opening possibilities for a trial. And then you have the 0%, and then you have disproportionate care as well. So disproportionate is in the one spectrum, but disproportionate is also in the other spectrum. And then you have harm without benefit, and those patients should not be in the ICU unless the benefit is, for instance, organ donation or giving birth to the fetus. And everything in the middle is basically appropriate intensive care. That's the most simple representation of what a trial of intensive care would be, but unfortunately there is another dimension as well, and that's the context. And patients, and especially patients, but especially family, needs time to adapt. If you walk into a room of a patient that was, let's say, an hour ago, fully active and social active, and then suddenly in a bed, and you say, well, the patient is dead, and they say beep, beep, and blood pressure, that doesn't land well. They need time to adjust. Then the patient needs to adjust his personal wishes. They need to adapt to the fact that, yeah, this is really going to end up in a nursing home with a trach and a peg, and that means that I can't do this anymore, I can't do that anymore. They need time. And there's a resilience as well. You have many patients say, oh, no problem, let's go for it. And so this makes things a lot more complicated, but I think, to be honest, also more interesting. So one of the elements that I see in my practice in the United States is they hardly talk about dead and dying. The families I've interacted with almost always thank me at the end for my candor, because I come in and I say, I'm very sorry, but your daughter is dead. And then I shut up. And some of the families have reflected to me like, no one ever said that to me. But if this is the case, yeah, then please let's stop treatment. So in your communication with family and family members, or maybe even patients, do you use the word like dead, you're dying, you're not going to survive, let's say these very vocal expressions, frequently, sometimes, rarely, or never?
Jan, I don't know how many slides you still have left, but I think we should come to a...
We are at the end.
More.
So frequently, yeah, that's very good. That's a very nice paper by Workman, Never Say Die, as treatment fails, words must not. It's something that is, let's say, very resistant in the US. They have a huge problem being candor. And I think it's incredibly important because candor creates, let's say, the limits of your trial of intensive care. So, at the end, now that we discussed all of it, the disproportionate aspects, the trial of intensive care, let's vote again and do the same vote as we started with. What's your opinion about the patient? I would proceed with full treatment. I would go to comfort care and stop all treatment, or I would ask palliative care. $85, so it increased from 60-something to 85. I don't know if anyone wants to respond. Is this because you had a clear insight on disproportionate care or anything else? I think the element in this case is disproportionate care, to be honest. There is no meaningful, at least as we can assess in clinical practice, there's no meaningful outcome, and there's a lot of harm to be added if you go on with treatment in this patient. Open for any questions, I think.
Yeah. Jan, thank you very much for your very clear